guys along the way. I'm Adam Niedelman, I'm one of the cardiologists here, I've been here for like 11 years. So just a couple things is where I'm gonna come at this from. No one's expecting you guys to be cardiologists, obviously. You don't have to be for what you guys are doing. I also am like an ACLS and BLS instructor. So I sort of approach this thing for you guys the way I would to get you through like an ACLS class, because that's honestly what you guys need, like tachycardia with a pulse. I mean, you guys are looking to put out fires, not solve the world problem here. The AHA, Tori made a copy of this stuff, it's a lot.
Yep.
They used to teach an actual EKG and pharmacology class, which was perfect for this, but they don't do it anymore, so these books are not really available. This is the last one we have from a couple of years ago, but it has good examples, but she has some there that you guys can make copies of, print stuff off with. But the way I sort of go through this is the same way I go through it with people and students when we go through ACLS, because not everyone has the same sort of, comfort level with cardiac stuff. And Tori just mentioned you guys had some with SVT upstairs. So I think there's 2 or 3 things I like to go through first, and it takes a little bit of a while, but I think once you guys have a basic understanding of sort of basic cardiac, especially focus on an EKG stuff here, once you realize how it works, it's much easier to understand how it can go wrong, and especially when, you know, the bleep is hitting the fan and they're showing you things and you're not used to dealing with this kind of stuff. At least taking a step back and eliminating things that you know that it's not before you know what you're dealing with here, okay? So this little thing that I handed out, you guys can, I made this up myself from when I teach ACLS. Feel free to make copies and do other things. The 2 things I want to point out is the anatomy of the heart, which is the electrical system, which I'll review very quickly. You know, write on these, take notes, whatever you got to do. And then how it translates to the surface EKG, which is in the upper right-hand corner of the sheet, okay? And we're assuming everybody's sort of normal to begin with here. We'll go through some of the abnormals in a second. So someone is in normal sinus rhythm, what happens? Your first impulse from the heart comes from the upper right atrium, which is your SA node. It fires out a signal to tell the heart to beat. And that's represented on the EKG as a P wave, okay? Then the signal goes to the AV node, which is, I want you guys to sort of think about the AV node as the entrance ramp to the highway, all right? Basically, the signal has to sort of organize. There's a little bit of a delay as you're sort of merging, and that's what represents the AV interval, the PR interval on the EKG. And then once things get through the highway and go down, if you guys remember, the heart has these Purkinje fibers, or the bundles, which are the most rapidly conducting fibers in the heart, and that allows the impulses to shoot to all areas in the bottom of the heart to allow the ventricle to contract, and that's represented by the QRS complex. The reason it's important to understand where those things are coming from is, if there's for instance, things can be wrong anywhere in the heart. So if there's no P waves, we know something's messed up in the atrium. If there's a big delay in the PR interval, we know something's going on around the AV node. And then if the QRS starts looking abnormal, or there's something wrong with the QRS, we know we're looking at somewhere in the ventricles. It helps us sort of like start to think where in the process of things are going wrong, okay? Don't forget, the heart's a funny shaped structure. It's this conical straight structure, and it's a pump. It's trying to be as efficient as possible. So for the heart to be as efficient as possible, when the ventricles beat, all the areas of the heart should come in at the same time. It doesn't want to be playing like ping pong with each other or anything like that. And that's why these Purkinje fibers allow the impulses to spread all the areas of the heart at the same time, so the heart can pump in unison, and then you get a nice, good output from the cardiac output, all right? 2 things to remember is with the EKG, it tells you 2 things. The EKG is stupid. It's up to people to determine what's going on. The EKG tells you direction, and it tells you time. That's it, okay? Things going toward a lead on the EKG are represented as positive deflections. Things going away are represented as negative deflections. Things that are happening quickly, as you guys just saw with the SVT, are very narrow, or they're happening close together. Things that are slow or spaced apart or wider are just slower. They're just happening in slower time, but it's us to figure out what's going on, okay? The best example I have to sort of relay that point home is when we talk about like what a bundle branch block is. We throw around that term all the time. You guys read it off the top of the thing. Yep, you got bundle branch block, cardiology. We all know how it works. But I think once you guys understand that, it helps sort of break down where we're going with things. All right, so if you remember when we're talking about the His-Purkinje system, there's 2 bundles. Well, there's actually 3, but 2 major sides of the bundles. There's the left side, or your left bundles, which is made up of 2, and then the right side, which is your right bundle. So when the impulse comes through that AV node and goes shooting down that wires, some goes to the left, some goes to the right. And when everything's working normally and everything's conducting quickly, your QRS is nice and narrow, right? A normal QRS is less than 3 little boxes on the EKG, or 120 milliseconds. Starts getting wider than that, then by definition, things are taking a little bit of a longer time, okay? So what exactly is a bundle branch block and why does it look the way it looks? We can start with a right bundle branch block, which is pretty common in young people. It happens with age, it happens for no good reason. You guys will see it when the pulmonary system's under stress, because don't forget the right side of the heart is feeding into the pulmonary system. So what would happen? Let's say this right bundle, which is right here, this wire on the right side of the heart, trying to point to the right side, becomes blocked, all right? This is the right side of the heart, doesn't work anymore. So what's your EKG gonna look like? There's nothing wrong with the SA node, so you're still gonna get a P wave. The impulse is gonna go through the AV node. There may be nothing wrong. You may not get a long AV interval or anything like that. But now, when the impulse wants to go down the heart, it can't make it down the right bundle. So what's gonna happen? It's gonna go down the left side of the heart very quickly, and then the cells in the heart, every cell can conduct electricity. It's sort of like our backup mechanism. So God forbid these bundles don't go out, we don't drop dead. The impulse can still conduct, but because it's not using these super highways, it's gonna take longer. So what happens in a right bundle branch block is the impulse comes down and can't make it down the right, so it goes shooting down the left, and it goes cell by cell by cell over to the right to finish off the job. So what does a right bundle branch block look like on an EKG? Everybody knows the rabbit ears, and it's positive in V1 and V2, right? So don't forget, when we put the stickers on the chest, we have V1, V2, V3, V4, V5, V6. In general, that's sort of how they go. So if you think about the heart sitting in the chest like this, when someone has a right bundle branch block, the image comes down quickly to the left and then has to go cell by cell by cell towards the right. So it's going towards V1 and V2, so it's positive, and it's taking forever, so it's wide. So that's why the right bundle branch block looks like that on an EKG. The left bundle branch block is the exact same concept, it's just the opposite, okay? So the impulse can come shooting down the heart, but this time the left bundle doesn't work, okay? So it's gonna come shooting down the right side very quickly, and then go cell by cell by cell by cell over to the left. So what does a left bundle branch look like? It's positive and it's wide, but it's wide in V5 and V6 because it's shooting down the right very quickly, and then cell by cell by cell, it's working its way towards the left of the heart, which is towards V5 and V6, so it's positive in those leads. So if you sort of start to just grasp those concepts, it becomes a lot less intimidating to look to see what's going on, okay? The two biggest rule of thumbs I always go through with you guys when we go through the different rhythms that come from the heart. Number one, and this goes for pretty much anything in cardiology, the lower down in the heart it's occurring, the more dangerous it tends to be, right? Ventricular fibrillation is much worse than atrial fibrillation. Ventricular tachycardia is worse than atrial tachycardia, okay? The heart blocks that occur lower in the heart are worse than the heart blocks that occur higher in the heart, all right? The second thing is, when it comes to these Purkinje fibers and the QRS and all that kind of stuff, the biggest thing is, if you guys remember from your ACLS class, when you do tachycardia with the pulse, there's an algorithm for that, and you go through the chart, and any third grader can follow a flow sheet. If you notice, even though there's like 7 or 8 different rhythms your heart can go into, that algorithm, even for ACLS, does not name one actual rhythm that you have to say, oh, it's AFib, oh, it's SVT. Oh. It just asks you to describe what you're seeing. It asks, is the rhythm narrow or is it wide, talking about the QRS, or is it regular or irregular, okay? The rule of thumb you guys have to stick to is the only way for the rhythm to use these highways and keep the QRS nice and narrow is to get on the entrance ramp. It's got to go down through the AV node. The point being, if you have any type of rhythm that these patients pop into and the QRS is narrow, you know whatever's going on, it's got to be coming from the top of the heart, because at some point the rhythm's organizing, going down those highways and keeping things narrow. It can't hop on the highway from the bottom of the heart. So if you start having fast rhythms from the bottom of the heart, even though they're going to be speeding along, they're still going to be wide because they can't hop back up and get on these highways. So that's why ventricular tachycardia is wide. It tends to be wide because, yes, it's speeding, but it's using the back roads. It can't use those fibers, and nothing conducts as quickly as these wires, all right? And then when we get to regular and irregular, that's when we start picking apart our irregular AFib, which we'll go over, and all that kind of stuff. But that's sort of the basics. When you see a cardiologist sort of look at these things, this is what's been ingrained in us in our training. We not only look at the rate and the rhythm, we also say, all right, I see P waves, I know the SA node's okay. How's this AV node? Is there something going on in the AV area? No, that looks all right. What do the QRSs look like? Are they narrow, are they wide? That lets us know where in the heart this may be coming from. Is the ventricle sick and all that kind of stuff. Now, obviously, that's very basic. The caveats being, and you'll even hear us for it, the first thing I'll ask for when I'm evaluating a sick patient or anything like that, or even something urgent, is like, the old EKG is critical, because if you don't know if someone has an old left bundle branch block, it's always going to be wide. And if they flip into something fast, your wires on the bottom are already screwed up, so it's always gonna look like wide. So someone with sinus tachycardia, but a left bundle branch block, yes, the QRS is gonna be wide. And if you don't have an old EKG, you are working with one hand behind your neck, but that's not just you guys, that's everybody. Some of my patients that have a left bundle that they're just walking around with, and I know they have it, I even tell them to keep a little copy in their wallet, because God forbid they're traveling and they get sick in like Michigan and they throw an EKG on them. You guys know if they think it's a new left bundle branch block, that sends off a whole chain of events as opposed to someone that's walking around with one, okay? Basically, the P wave is nice and small because the atrium is a very small, thin tissue. The QRS is the big, massive ventricle, big, massive muscle, so it makes a bigger spike. That's the only reason it looks bigger on the EKG. But that's sort of the framework that I'll go through as we start to pick through these rhythms. And once you sort of think about it that way, it's not as intimidating. Because if you can say, all right, there's really only two rhythms that come from the bottom of the heart. There's ventricular tachycardia, and there's ventricular fibrillation. Okay, ventricular fibrillation is not compatible with life. So they're not gonna be talking to you sitting there in VFib. If someone's in ventricular fibrillation, that's code time, ACLS, chest compressions, immediate defibrillation. Ventricular tachycardia can span both. So, when we break it down, there's fast heart rhythms the heart can go into, and then there's slow heart rhythms that the heart can go into. But the fast ones tend to be a little bit more intimidating, but that's sort of where you have to start thinking. Someone goes into, like you said, SVT, it's narrow, it's fast, you say, all right, it's coming from the top of the heart, what do I need to do here? And I'll sort of work through these with you a little bit to break down some of the most common rhythms that you'll see. Any questions on that? That makes sense to everybody a little bit?
It's very timely considering.
Yeah, no, that's what I figured. Yeah, no, it just gives you guys, take a deep breath
Yeah.
and
Yeah.
to go through these things. All right, so one thing I will show you is, I know you guys don't all have this book, but I'll try to use this here. That's all.
I have copies of it. So
Yeah,
if you're
all right,
on this
perfect.
page.
I don't know for the sake of what you guys need and the sake of what you guys need as far as counting a heart rate goes, you can usually trust what's on the machine. People that do this for a living, you memorize the boxes. If you count one box, it's 300, 150, 175, 60. It sort of matters. I mean, not that you guys need to know that. By definition, I'm sort of a stickler for definitions because I think that helps you guys know what you're talking about, and especially when you're relaying information to someone over the phone, and I'm not picking on you guys, there are doctors here that don't use the right terminology, but it makes it very hard to help people over the phone without that. By definition, something's considered tachycardic greater than, what's the definition? 100, and less than what is Brady? 60, right? And that's just by convention, all right? So we're gonna start breaking down some of these rhythms. I'll go through a couple with you, and then there's like a packet of them that we can try to do, just so you can see the thought process with these things. We usually look to see are there P waves, which lets us know the SA node's working. What's the AV interval look like? How's that working? What's the QRSs look like? When we get into more of the heart blocks, we're gonna see, does the P wave, is it responsible for what's coming after? Like, is everything talking to itself? But in the faster rhythms, we sort of determine, all right, where's the problem coming from? And before you guys shout out the rhythm, even if you know it, I like to have we say, all right, is it narrow or is it wide? Because once we say that, it takes half the stuff we can be looking at right off the table. And then is it regular or is it irregular, okay? So these are very basic rhythms you guys can see here, not that this is anything earth-shattering. So you have a P wave, which tells us that the sinus node is working okay. A PR interval here that shows it's less than one big box, so the AV node is conducting okay. And then the QRS. So this is what we would consider more of a sinus rhythm. You can see here, this is what we would consider a sinus bradycardia, because the P waves are firing, but they're pretty slow. The P waves are coming at less than 60 beats per minute. Everything has its own rate. Like when everything's going okay, like this P wave leads to this QRS, then this P wave leads to this QRS, then this P wave, they're all gonna have the same rate. But like when someone's in heart block, for instance, and the P waves are doing their thing and the QRS, we may say, well, the P waves are going at this rate, but the QRSs are, everything can have its own rate. But when everything's working in unison, they're gonna have sort of the same rate, okay? So in this situation, the SA node is, if I was thinking about this from a disease standpoint, all right, I have someone in sinus bradycardia, so what's going on? All right, so the SA node or the P waves are firing at a slower rate. So I say, all right, the SA node is either sick, it's old, or they're on medicines that slow it down, or they're in insanely young and good shape because they have very high vagal tone. But what else can I say? Yes, the sinus rate is slow, but how's the PR interval look? Normal, right? It's quick. I mean, the PR interval is short, it's less than one big box, and the QRS is narrow or wide? Narrow. So, but I can also say, once the beat leaves, everything going downstream is working fine. There's no further disease at the AV node, there's no extra delay there, and then the QRS is nice and narrow, so those wires are working fine. So it lets me focus where my problem is, it's all at the SA node. Now, if we start to see sinus bradycardia with a long PR interval and then a wide QRS, then all of a sudden I say, all right, well, not only is the SA node working slowly, then things are taking a while to get through the AV node, and then once it hits the wires aren't, then I say that's a more diseased heart top to bottom, if that sort of makes sense. That's why breaking it down seems okay. So these are all sort of the same type of thing. Sinus tachycardia, again, sort of the same thing, where the P waves are firing out quicker than typical, but everything else is conducting normally once it goes through. One thing that I skipped through because you guys don't have it, but it's a very nice thing in here. This page that Tori copied has all the normal sort of intervals of what everything should be. Just so you guys know, and it's probably more than you want to know, basically, you hear these terms, intervals, segments, all sorts of crap about EKGs. I think, again, it helps to understand the definition when you're talking about these things. When we're talking about an interval on an EKG, it includes one of the deflections, okay? So a PR interval goes from the beginning of the P wave to where the PR interval ends. The PR segment is just the part in between, but because it includes the wave, it's the interval. That's why when we talk about ST elevations and stuff, we're talking about the ST segment, just the pieces between the waves. But when we have a QT interval, it includes the whole T wave. That's why it's called an interval, not a segment. Okay, that's just more convention. But this is all in that book if you guys could look through it. All right. So as far as looking on here, I basically sort of told you we'll stick with the fast ones for now because there's a lot to go through. When it comes to these rhythms, we know how it works normally now. So from the bottom of the heart, there's really two rhythms your heart can be in. We talked about ventricular fibrillation and ventricular tachycardia. So is everybody familiar with what ventricular fibrillation looks like? Because that's a critical one to know. With this one, you sort of got a tattoo on your brain because this is not compatible with life. This needs immediate ACLS, call the code, get chest compressions, and shock them as soon as humanly possible, okay? Typically, I guess with what everyone's seeing now, it can come for no good reason. This has typically been associated with coronary ischemia. So don't forget the heart's a pump. The pump needs a lot of oxygen. The heart and the brain need more oxygen than anything else, as you guys are aware. That's why we try to educate the public. If you think you're having a stroke, lack of oxygen in the brain, or chest pain, lack of oxygen in the heart, get seen right away, because if the heart's not getting oxygen, things happen very quickly. When someone's actually having a heart attack, the heart blood flow is being interrupted. Takes only about 30 minutes for you to start suffering irreversible damage sometimes. And the pump, these wires, basically when I go over stuff with my patients in the office, if you're looking at the heart, the arteries, the coronary arteries run on the outside. I tell them the plumbing runs on the outside, the wiring's on the inside. So if you have a blocked coronary artery and all of a sudden no blood flow is going to this muscle, every wire that's sitting underneath that muscle is prone to do something like this. And that's why they go together, okay? So there's really no magic treatment for this. It's shock, CPR, and definitely get everybody involved. Now, what does ventricular tachycardia typically look like? Is it going to be narrow or is it going to be wide?
Narrow, complex.
All right, so we just talked, so where's ventricular tachycardia coming from as far as so what is ventricular tachycardia?
Come from the AV node.
Ventricular tachycardia, where is it coming from? From the ventricle. So let's say it's going to start somewhere down here and then fire off and go very quickly, okay? So sticking with what I just told you, if it's coming from the ventricle, is it going to be narrow or is it going to be wide? It's got to be wide, right? Because it's not coming from above the AV node. So typically, when people have ventricular tachycardia, don't forget, the EKG is showing us two things. It's showing us direction and it's showing us time, okay? So most people recognize it when they see this. So this is a decent example of ventricular tachycardia. It's going fast, so it's tachycardic. It's over 100 beats per minute. And the QRSs here are wide, right? Everyone agree on that? So if it's not narrow, we're taking away all the rhythms from the top of the heart. So it's got to be one or the other. It's got to be VT or VF. What do you notice about these QRSs compared to one another?
They're not the same.
They're not, or they are?
They look
They're identical, which means what, thinking about how an EKG works? If they look exactly the same, what does that mean?
It's coming from the same place.
It has to be coming from the same place in the heart because they look the same, right? Because the EKG is just telling us what it's seeing from the outside, okay? So the most common people that get ventricular tachycardia, or these bad heart rhythms, you don't see 20-year-olds having this stuff. You guys see it. I mean, you don't deal with it, but you see it. It tends to keep the company sicker people or sicker hearts. So you see ventricular tachycardia in the old farts, people that have either had open heart surgery, people that are on 1 million blood pressure pads, people that are diagnosed with congestive heart failure. ventricular tachycardia tends to keep the company of sick hearts. Typically, from an anatomic standpoint, when someone has monomorphic ventricular tachycardia, meaning there's one spot in the heart that decides to fire up, it's because they have a scar in the heart muscle. And what's a scar? It's a myocardial infarction. So if they've had scarring from an old MI or scarring from just years of heart failure, when people have congestive heart failure, just like if you have a bad shoulder that you never get treated, you get fibrotic, you get tissue. I mean, if you look at a biopsy of someone with heart failure, it's not beautiful muscle under there. There's scar tissue, there's inflammation, there's all sorts of stuff. So one of those spots decides to short circuit the electricity and boom, it's off to the races. And that's why it's wide, because it's coming from the bottom of the heart. And then it's also coming from the same spot, so it's gonna look the same. So usually when we see something like this is not typically, especially if it's sustained like this, lasting more than like 30 seconds. So it's usually coming from a scar in someone's heart. So this is ventricular tachycardia, or more specifically, monomorphic ventricular tachycardia, because it all looks, one morphology, it looks the same, okay? Now, just taking you guys back to the ACLS stuff, don't forget, you can have monomorphic ventricular tachycardia and the person can be coding, where they're unconscious, they have no pulse, they have no blood pressure, and if that's the case, they need immediate chest compressions, they need to be defibrillated immediately. You will have patients that flip into this in the ICU who like just got extubated or something like that, and they're like talking to you. And they're saying, oh, I guess maybe I feel a little bit dizzy, but they're not dead, okay? So occasionally, this is not something you guys would be delving into on your own, but just because they have this does not necessarily mean they need to be shocked right away. You do have to take the clinical context into play, okay? So if you guys remember your ACLS algorithm, tachycardia with the pulse, it will drag you down to, is it narrow or is it wide? Talking about the QRS, you can say, all right, it's wide. And if they're not unstable, which I'll talk about in just a second, you can give them meds for this. These are the people that we give like amiodarone to, or sotalol to, these anti-arrhythmic drugs, which are just that, they're anti-arrhythmia. They try to get you back into a normal rhythm. But usually once you guys are going down that road, someone else should be, I would argue someone else should definitely be, I mean, aside from the acute setting, 150 of amio, never gonna hurt anybody, but to get, if this is gonna be a thing, you guys should have someone else
That's
helping
good
you
to know.
along with us. Yeah, amiodarone is a pretty benign
Okay.
drug. The reason I bring that up is, and this is when I want you guys to take a step, especially working in the ICU in situations where you guys are being thrown into sort of a crappy situation, you know, you're doing stuff, it's bad enough if this was your line of work and having to deal with it, but you're getting pulled out of your normal context. This sounds stupid, but I say it out loud because you can talk yourself into a tizzy, or I say it to patients all the time because they think you're discounting what they're saying. If someone has a fast heart rhythm like this, there's a difference between symptomatic and unstable, okay? And that's a very big delineation to make, because how you're gonna act between a symptomatic patient and an unstable patient can have dire consequences, okay? If someone comes in atrial fibrillation with a heart rate of 150 beats per minute, and they say, my heart's feels like it's racing, and you know, but you do their vitals and their blood pressure is 120, they're not having chest pain, they're talking to you, they're mentating. Are they symptomatic? Yes. Are they unstable? No. And if you treated them unstable and say, oh my God, we gotta shock you, you can have dire consequences from that. The same goes for ventricular tachycardia. As much as you would think, oh boy, they're gonna die on me in 5 seconds, you have to assume they could, and you always wanna have like pacer plaids around, you wanna get experts involved, you don't wanna sleep on this. Symptomatic, they may feel a little bit dizzy, a little bit woozy, they may say, you know, maybe their normal pressure is 150, now it's only 120, they don't look great, but their pressure is not 60 and they're not ready to code on you, you can still treat this with medication, okay? Symptomatic is not the same as unstable, so before you guys do anything dire, don't treat the rhythm, treat the patient, and that's important for you guys to know, because if you do something, obviously you don't want to under-treat somebody, but on the other hand, over-aggressive treatment has consequences too. So just take a step back and be like, all right, yes, this is ugly, but I do have the 10 minutes waiting for the cardiologist to call back before I go make this guy sleep and put on pads and shock him. Just make sure you guys are, you know, understand the difference between the two. And it sounds stupid when you say it out loud, but when you're sitting there, there's a huge difference between symptomatic and truly unstable. And that's a big fork in the road with any ACLS treatment. If you guys remember, the first box they always have you go to the left on, whether it be the bradycardias, the tachycardias, it's like, are they in shock? Are they not mentating? Do they have hypo? Because if they have any of those bad things, then yes, you have to act right away. But if you don't, you start working your way down the algorithm and sort of doing it a little bit more gradually with your treatments. Okay, so just don't lose sight of that and all this kind of stuff. All right. So the one thing here, and this is probably too much for you guys to do on a on an EKG on the fly class. Sometimes it can be tough to see if these wide complex rhythms are truly ventricular tachycardia, so definitely everyone has access that's available to these EKGs. You ask them to look at it, someone can look at it. If you look at this rhythm here, it's hard for you guys to see without digging through this with calipers. You can actually see little lumps in the thing here. These are actually P waves. So the heart is sort of, the P waves are getting lost in the shuffle here, and this is what we call AV dissociation, because the ventricles are off to the races, they're not listening to anything anymore. But you will actually see a little bit, and if you march this out with calipers or a piece of paper, these little P waves would actually march out, because when the heart, don't forget, normally the heart beats top to bottom, but in this case the heart's activating from the bottom to the top, and you can actually get P waves coming the wrong way. But that's more for you guys. I'd rather you guys just be able to recognize this and know if this comes on out of the blue, just to take a deep breath. This could be something, Sam, and call somebody and make sure that the person's obviously not coding. The other things with this kind of stuff that's stupid, but it gets you some sleep at night. When I used to run CCU rounds and all that stuff, it takes 2 seconds in the morning to make sure like the magnesium's around 2 and the potassium's around 4. Especially if patients are getting like diuresed heavily. If we have patients that are getting like 80 of IV Lasix twice a day and putting out 2-3 liters of urine twice a day, or you guys even see it, they've been post-op and then they've been getting TPN, they're just so volume overloaded, and then finally the floodgates open and they're starting to equilibrate their fluids. You can't keep up with the potassium and the magnesium. When they pee, it's not just water a lot of times. You can save yourself a lot of sleep correcting the magnesium at 7 o'clock in the morning instead of them having these rhythms at 3 o'clock in the morning. You realize magnesium's like 1.1 now. You can only put it in so quickly, okay? Those things will affect like the QT interval and stuff, and just make, don't forget, magnesium, potassium, in short, stabilize the cardiac membranes, and that's why it's less likely for them to go in it. And it's a stupid, easy thing to keep track of, and it's like one lost night of sleep and you'll never forget to do it again, all right? So the other thing that goes with the ventricular rhythms, the ventricular tachycardias, again, is this narrow or is this wide?
Hi.
You think it's narrow? Why do you say that's narrow, the QRSs?
I can't really tell. I mean, it looks narrow to me from here, but.
I mean, so this goes from here,
in the
middle.
this goes from here to here. So just for comparison's sake, this is what a narrow QRS looks like. You see how less than 3 little boxes. So don't forget, you're counting from here to here. So as long as there's more than 3 little boxes, it's considered wide. This one's right on the cusp, but it's still about 4 boxes, okay? So these are both wide. What do you notice about the two, as opposed to what we were just looking at before? What do you notice about this one?
It's not uniform.
Very good. So this is what we call polymorphic ventricular tachycardia, okay? More than one morphology. So this means this is not just coming from one spot in the heart. This is sort of coming from different areas that are activating at the same time. What term are you also guys familiar with if someone has polymorphic ventricular tachycardia? What's the classic French word? Torsades. So if you guys can imagine something like this being printed out in a much longer strip, you can see it getting bigger and then smaller and then bigger and then smaller. The QRSs are big, then they're small, then they're getting big again. Small, big, and small, okay? What's the treatment if you see polymorphic ventricular tachycardia?
IV magnesium.
Very good, IV magnesium. Now, oftentimes if it's like torsades, it'll come in bursts. It'll look scary as shit, and then it'll stop, but then it'll happen again, and then it'll stop. Sometimes it'll last 15 seconds, but it'll stop. If you give 2 grams of IV mag, almost 99% of the time it will settle it down. Now, maybe only for a couple minutes, but it will quiet things down,
How
okay?
much did you say?
Usually it's 2 grams.
2 grams.
Yep. People with the polymorphic ventricular tachycardia, a couple things you want to make sure are not going on. Again, you're always thinking about, all right, A, this is happening, but B, why is this happening? We talked about the monomorphic ventricular tachycardia usually being associated with a scar in someone's heart. When someone's having these polymorphic ventricular tachycardias, that's like a prelim of making themselves into something like this. This is like halfway in between them ending up fibrillating. Big things with the polymorphic ventricular tachycardia, one would be like acute ischemia. Are they having chest pain? Is there a big area of the heart, not just one spot, but now they're having, don't forget, if there's a blocked heart artery, there's a whole territory of heart muscle that's not getting blood flow, so it could be coming from different places. The second thing for this one, and we see this, there's once a year that we have someone that has this and it goes and goes and goes. This one's definitely like the electrolytes and the meds that you hear us always talk about, QT interval, of prolonging the QT interval. There are certain meds that stretch out that repolarization of the heart, and if it gets stretched too far, this is this is the rhythm those patients go into.
So if you have, because we have all these COVID patients on QTC prolonged.
Right, so that, I know that's a
all
real,
that kind of stuff.
yep.
Would IV magnesium still help if it's caused by?
It will help
QTC
temporize the
prolonged?
situation, but then you also have to figure out how am I gonna take away the inciting factor here.
Got it.
So the classic one, I've had 2 of these since I've been here, are alcoholics that come in that are taking like amiodarone or one of these antibiotics, because their magnesium stores are shot. Their potassium's like, 2.1, their magnesium's 0.9, and you have to give it to them for like a week to get it back up. And then they're on these meds that stretch out the QT interval, and they are having this for like days until you can, yes, you keep giving them mag and mag and mag and mag, but until you fix the underlying problem, that would be a cause. So this is, I know that's a thing with the COVID drugs. This is the, so this is the rhythm you do have to worry about with, this is why you're checking the EKGs on the COVID patients, is because this is what you're worried, if it gets too far out, this is what it makes them prone to, okay, the polymorphic PT. So you put out the fire with the magnesium, but then you would definitely have to start backing off on those things to keep it from going on. Again, you guys are just there to identify the problem, put out the fire, but then you're gonna call for help. No one's expecting you to be board certified cardiologist. I think my goal for you is just, and this doesn't, it sounds minimal, but it's not. It takes a very good skill to just recognize a problem. And then once you know there's a problem, you know, do I need help or I don't need help? Those are very good skills to have, and not every good doctor has those skills. So there's plenty of times in the ER where I'm like, why the frick didn't you guys call us like an hour? You have me seeing a 99-year-old with your opponent of 0.11, and the person over here just had this, and it's not just you guys that I'm picking on for like, there's a reason like the most senior surgeon is usually the triage guy, because you have to have that gestalt to be like, even just looking at this, even if you were the world's dumbest PA or doctor, does this look good or does it look bad? Just like looking at it like a work of art, right? So you gotta trust your gut sometimes. This does not look good, right? As opposed to like this. We're like, all right, well, I don't know what's going on, but it just doesn't, your gut tells you it doesn't look that bad. You have to trust your instincts, okay? So those are really the only 2 rhythms that come from the bottom of the heart. There's ventricular tachycardia, which can span a big clinical spectrum, symptomatic versus unstable, and then there's VF, which you would treat. Obviously, that would be a code. Are they coding the COVID patients or not?
Mm-hmm.
They are.
If they're still full COVID, they're trying to make most patients DNR,
On the way in,
Yeah.
I know,
especially
sorry.
once they're intubated.
Yeah, right, okay, I didn't know if they were still doing that. All right, so, the more complex ones, but these are the ones you'll see more often, but again, not necessarily as emergent, doesn't mean they're not untreatable, but they're not urgent, are the rhythm that comes from the top of the heart, okay? So, and as you can see from the list I gave you, while this is not all encompassing, these are the most common ones that you guys are gonna see coming from the top of the heart. So using my little schematic, my little general rule of thumb, if the rhythm is coming from the top of the heart, is the QRS gonna be wide or narrow?
Yeah.
Narrow, right? Because no matter what's going on up there, at some point the rhythm's going through that AV node and going down the highway, so you can say, all right, that guy told me behind his mask that at least I know it's coming from the top of the heart, okay? One I will point out to you that we see a lot, you guys will see a ton of, I'm sure, with this COVID, is sinus tachycardia, okay? Why is that? The sinus rate is going at 110 beats per minute. The QRSs are keeping up with it. Is that truly an arrhythmia? Sure, it's by definition, it's greater than 100 beats per minute. Sinus tachycardia is a physiologic arrhythmia. It's not a pathologic arrhythmia. It's your body's responding to something else going on somewhere else, okay? If you have a fever, if you guys have a post-op patient that has pain, if we all ran around the block 10 times and came in here, what would our rhythm be? Sinus tachycardia. It doesn't mean we need an IV low pressor, right? You want to assess to make sure what's the clinical situation that's leading to that. There's very, 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 if any times that there's any specific treatment for sinus tachycardia, aside from fix whatever's causing it. And if you get some of these young people that have, are really, unfortunately really sick, their heart's gonna be going. I mean, your heart is stupid. It knows one thing. If things aren't going right, it usually works faster. That's the only thing it knows. If it's weak, it goes faster. If you're in pain, it goes faster. It doesn't know how to regulate itself otherwise. And don't forget your maximum heart rate. Your maximum normal heart rate is 220 minus your age. So if you have a 30-year-old that's really sick, their sinus rate could get to 180, 190 if it had to. An 80-year-old, on the other hand, 220 minus 80, you'd expect their sinus rate to only be, max out in like the 120, 130 range. But, if you ever walk through like a PD ICU, those monitor, 140, 150, they don't blink an eye because those kids, if that was our ICU,
That's normal.
right, our ICU, what the hell, why is that guy's heart, something's gotta be wrong with that guy. And actually with all these bad rhythms, if someone comes in, this is a little bit more than you guys need to know, If someone comes in with a major heart attack, like a massive MI, where they take out like the whole LAD distribution, the whole front part of the heart doesn't work anymore, the worst prognostic rhythm that they can have for a poor outcome, people would think it would be VT or VF, but you can shock those. If someone's sitting there that just took such a big hit to their heart pump, and they're sitting there looking at you, and their heart rate's like 100, a sinus tachycardia, 110 beats per minute, it means their heart has gotten so weak now that it's pumping fast already, because don't forget, if the heart's not gonna pump strong, it's gonna pump faster. Cardiac output's heart rate times cardiac output. So if your cardiac output's in the tank, heart rate's gonna go up. If someone has a big MI and they're sitting there with sinus tachycardia, that's actually the worst thing that they could have, because you know they just took a huge hit to what's going on underneath there. But it's a physiologic arrhythmia. There's very little specific treatments for sinus tachycardia. Now, this isn't to say you may not see the pulmonary docs or even us every once in a while to keep us from getting called all the time. Give a little IV metoprolol from time to time to slow it down. If you think it's always a little bit more complicated than being said, but just don't think you're fixing the rhythm by giving any meds for sinus tachycardia. My point being, if you have an 80-year-old guy who's, God forbid, got COVID, and he's trying to wean, and it's being stressful while he's weaning, so his heart rate's going up, but he also has like triple bypass from 30 years ago, and we know he has some blockages, and every time his heart rate gets above a certain threshold, then he starts to get a little bit ischemic, and it sets off that whole. We may try to knock down his body's physiologic response to allow but we're not fixing anything it's not like SVT where we're trying to get him out of it. We're not trying to fix it, we're just trying to temper what his body's trying to do on its own, okay? So I would argue the two most common rhythms, and they're sort of close cousins, I usually spend the most time on these rhythms that people see from the top of the heart, are atrial fibrillation and atrial flutter, all right? So this is where sort of definitions come into play, and I can give you guys you said you guys see a lot of AFib, right? I can give you guys a much briefer, just sort of focused talk on AFib, even later in the week, just a couple PowerPoints just to think through that. But as far as if you saw someone pop into AFib on the monitor, what exactly is happening? The atrium's fibrillating, right? So by definition, what are the two things that you see on a monitor to tell a patient they have atrial fibrillation?
No P waves.
Very good, no P waves, because the atrium's fibrillating, so you won't see that. And then how do we describe the heart rhythm? Irregular, okay? And that's it. So I always tell patients, a lot of people call everything AFib, especially even the tele nurses. And I'm like, CAT doesn't spell dog, it spells cat. By definition, if you see P waves, it's not atrial fibrillation. You gotta go looking for something else. But there's no P waves, and the heart is irregular, okay? So sticking with our map, what exactly happens? The atrium are fibrillating, they're just that. So if you put a needle, you open up someone's chest while they were in AFib and they were still alive, and you actually just put a little pin in the atrium, it would actually be going at like 400 beats per minute, okay? So it's actually bombarding the AV node with impulses just like constantly. It's not coming from one focus anymore. This is where we're happy that this AV node acts as like the entrance ramp to the highway. It doesn't just look everything down. The AV node goes, whoa, whoa, whoa. I see you guys, but we can only work so fast here. So the AV node is trying to keep up with what's going on up top. But typically when someone flips an atrial fibrillation, the fastest you'll see them go is maybe 150, 170, 180. That's like the fastest the AV node can let cars down. And then once it goes down to QRS, okay? So it's not that the heart rate is fast or slow, but the AV node is actually, because if AV node let every beat down, then AFib would turn into VFib and we're dead. So it's actually protecting us by not letting every beat make it through. It may not feel comfortable for the patient, it may look ugly on the monitor, the patient may not feel great. Atrial fibrillation is very, very rarely acutely life-threatening. It's usually a piece of the puzzle or something we need to do about it. Sometimes if someone's very sick, it's like sort of the last straw for people, and it doesn't help the situation. But that's really what's going on, is the AV node is being bombarded with signals, and then it's letting through as many impulses as it can. The reason I phrase it like that is if someone's 30 years old and flips into AFib and their wires are smooth and they're going, they may go up to 170, 180. You have a 90-year-old whose wiring is already starting to slow down. I have patients that walk into my office and I'm like, oh, your PCP found you an AFib. They're on no meds whatsoever, and the heart rate's like 95 beats per minute. Why is that? The atrium's still fibrillating, it's still flying, but that AV node is so diseased now, it's like almost like having a construction sign up at the highway, saying, all right, yeah, that's great, but at this point, dude, I'm 90, only like 90 beats per minute are making it down here, so they don't need any extra meds to slow them down. But as a cardiologist, that tells me, yes, they're an AFib, but he's got some disease in his his heart is telling me he's got conduction disease. Because the atrium is still fibrillating, but the AV node is only letting in 90 cars at a time. That's not what it normally should do. Normal AV node lets in at maximal capacity like 100, 150, 150, like 180 at a time, and I'll talk about that more in a second. If someone's in AFib, irregular, and the heart starts going fast, what kind of meds do we usually give to like slow things down?
Depends.
Okay, beta blockers. What else are you guys thinking? We use it a lot around here.
Calcium.
IV, diltiazem, and the other biggie we use is digoxin, okay? Now, just so you guys understand, those meds are not meant to flip the person out of the atrial fibrillation, okay? That may happen just by settling the dust down a little bit, the body, nature taking care of things on itself. When we give meds that go to the heart, and this will be a little bit more in the AFib, but it may cover everything now. When we give meds that affect the heart, and you talked about beta blockers, calcium channel blockers, digoxin, where in the heart do they work? Where do they typically work, most of our meds? I'll give you a hint. There's 2 places, and I already mentioned them. All right, a little more specifically, though. Where in the atrium? And not the ventricle, but where? What's the key part? That the AV node, okay? So when we say those are nodal blockers, a beta nodal blocker, a calcium channel nodal blocker, they're just slowing conduction through the AV node. So, for instance, if someone's got a heart rate of 180 beats per minute in AFib, and then all of a sudden I put them on some IV diltiazem, they may start to look like this. We have not slowed down the atrium at all. The atrium's still flying away, but now the AV node's saying, things are not going through here as quickly, and what you're really looking at down is not slowing this down, you're looking to slow down how many beats make it to the bottom, okay? So that's what you're doing with those medications. That's what we call rate controlling the atrial fibrillation. You're controlling the rate by controlling how many cars are making it through that AV node. That makes sense to everybody? The QRS here is still narrow. There's nothing wrong with the ventricle once the beats make it down. The wiring down there is fine. So this person has no P waves. The heart, if you march this out, is sort of irregular. So this is atrial fibrillation. But someone going this sort of slow, this is about 80 or 90 beats per minute, is either really old, or you have them on some meds that are keeping the heart rate from going at maximal capacity. That make sense? Everyone's good with that? Okay. So this is a good one to sort of look over. So the other one that's that's close to AFib is something called atrial flutter. What's atrial flutter usually look like? Very good. So this right here is atrial flutter. It's very distinct looking. They go through it in ACLS. You guys should have gone through this in ACLS class. So what are those sawtooths? You guys know?
It's the atriofibrillating, or fluttering.
Very good. So, but if you notice, they're much more regular and organized. This is whatever these sawtooths are. They got a rhythm to them. They're coming at they're not like one sawtooth and they have not. So, remember when I said your atrium and your ventricle can have different rates, right? So the reason atrial flutter becomes difficult, and I don't think this book has a great example of it. If someone sees like this much atrial flutter, even you guys know that's typically atrial flutter. It's so distinct looking, it's very easy to recognize. The problem is if the QRSs are not being separated by 4 different flutter beats, what exactly are you looking at? And it can be difficult to decide what you're actually dealing with as far as the rhythm goes. Again, taking a step back, the QRSs are nice and narrow here, right? So at least you know you're coming from the top of the heart, so you know it's not VT or VF or anything like that. Atrial fibrillation is like chaos. So the atrium is literally fibrillating, and it's just bombarding that AV node with impulses from everywhere in the atrium. I try to describe it as like someone blowing confetti. I mean, it's just like trying to catch every piece of confetti that's coming from the sky. That's what the AV node is doing, okay? Atrial flutter, as you can see by this sawtooth, is a more organized rhythm, but it's treated very similar to AFib because they're both at risk for the whole blood clotting thing, okay? And I'll talk about that at a separate time. But people that have atrial flutter, like you said, the atrium are fluttering, what happens is in the right atrium, for whatever reason, some people are set up to have a rhythm that starts going counterclockwise, almost like a race car, around and around and around, just in the atrium, okay? This is a little bit of a difficult concept to consider. So instead of the beat coming from the AV node and going down, it's going around and around and around, like it's almost like someone spins a top in the atrium and it's just going around and around and around. And if you notice these sawtooths, this one's here, these sawtooths are at 300, these atrial beats are at 300 beats per minute. You see they're only one box apart. Now, the ventricle's not going at 300 beats per minute, but this atrium is like, this car is going around the atrium at 300 beats per minute. So what's going on? Every one of these sawtooths is an upside down P wave, essentially. Usually the heart beats from the SA node down, top to bottom. These things are going backwards, they're going up and away, so they're upside down, they're sort of going away from the bottom of the heart and spinning back around, okay? This is where I need you guys to stick with me just for a second so you understand what this is. So if you're in this funny rhythm where this is, you have something going around the atrium and just spinning, and that's going around at 300 beats per minute. It's gonna go around and send a beat down, and you get a QRS that makes it through.
Some cars get through, yeah.
Some cars don't, very good. So if it spins around again at 300 beats per minute, the AV node goes, that's wonderful, but I don't work at 300 beats per minute. I can't handle that, nothing's making it down. The rhythm has to go all the way around again, and then it goes, all right, well 300 every other beat, 300 divided by 2 is 150. That looks good to me. The AV node often lets every other beat down. So if you guys ever see someone that pops into what looks like an SVT, and it looks like it's right at 150 beats per minute or pretty close to that, as cardiologists, we're trained to sort of look for the flutter waves first or see if you can find anything, because it just is perfect for this making, for every 2 laps, 1 beat makes it down, okay? For this guy, or gal, I shouldn't say guy, the atrium is making 1, 2, 3, 4 laps for every beat making it down. So what do you think this person may have going on that even though the atrium is going at 300 beats per minute, only every 4th beat is making it down? It's something we sort of touched on already.
Their AV node is.
Something is slowing the AV node. Very good. So this person may be on diltiazem now, or he's on a beta blocker and he flipped into this. So it doesn't stop the atrium. The atrium's still doing its thing. You're putting a medicine down here that's stopping how many cars can make it down, all right? Now, if someone flips into a faster heart rhythm, I don't know if I have an example of this, I wish I did. Because the hardest one is atrial flutter with 2 to 1, because it's very hard to say, is it every other beat or is it SVT? I don't think I have one here.
Is the second one
Let's see.
in the packet? It kind of looks like something.
Right, so very good. If you guys can open up the second page of that packet.
Okay, here.
Yeah, this is good. I knew I had one. All right, so before we even get running into diagnostics here, if you guys are, all right, Nurse Sally from bed 9 in the CCU, it's 3:30 in the morning, comes running out with this and says, all right, what do you think? You're gonna take a deep breath and you're gonna say, okay, are the QRSs wide or narrow? Narrow. So we're not talking about VT or VF, right? You can at least not change your underwear yet. And then the second thing is, does it look regular or is it irregular?
Irregular.
Regular.
Regular.
I would argue that's right. The QRSs are coming. If you took a piece of paper and just sort of marched, you know, if you don't have calipers, the best calipers ever invented are a piece of paper.
It's
You
not
just,
normal, but it's regular.
the QRSs are coming at a very regular rate, right? So what does that take off the table?
AFib.
AFib, right? So you've already done a lot of work without even figuring out what this is. You've taken out a ventricular rhythm and you've taken out AFib. So what are we sort of left with here? This is either going to be SVT, which we haven't talked about yet, or this is going to be atrial flutter, okay? So what do we notice about the rate of the ventricle here? The QRSs are about how fast?
125-ish.
Yeah, so it's a little less than 150, a little more than 100. So it doesn't really go with my thinking of right on 150, but it's not going 200, right? And it's not going 90 either. It's sort of right on there. Now the question is, are there flutter waves in here? So the best places to see flutter waves are like leads 2 and leads 3, and if you're lucky, way over in V1, because don't forget, those sit right above the atrium up here. So look at that rhythm strip of lead 2.
Not
You-
the normal. Not
the-
the normal.
It doesn't look, you don't really see like P waves, maybe you do, maybe you don't, but it looks sort of wavy in there, right? So I would argue, you know, I do this for a living, this is a little easier for me to say. Looking at this, before you guys go running in it, so you look at this, we already said if you saw this, you would know right away what it is, right? If you thought this, maybe the same rhythm as this, what would you do to help you out? How can you help make the diagnosis? What can you do? What do you need to do? You just need to see a couple more of those. If you just saw this, even for 6 seconds, you'd be like, yep, that's flutter. You don't have to see a minute and a half of it, right? So if you thought there may be some flutter waves in there, we already said this guy you're seeing more of them because you slowed the AV node down, right? So if you wanted to slow her AV node down just to see if there's flutter waves, what kind of stuff can you do?
Beta
Beta
blocker.
All right, let's say before, so that's not a bad thought, but even before you get to that, you just need like 5 seconds of it.
Oh,
Basic.
Vagal. So you can either go in and push on the neck. All you're looking to do is slow it down just long enough to see a little bit of that, because once you see it, you're like flutter, there it is. The other thing you can do is either try to give a beta blocker. What's the most potent AV node blocker that's out there? It's on your little thing. It shuts it down. It puts up the stop ramp.
Oh, adenosine.
Adenosine. So adenosine is classically given for what rhythm?
Or VTAC.
Not VTAC. No.
SVT.
SVT.
Yeah.
That's from ACLS. So supraventricular tachycardia is, which we haven't gotten to yet, but SVT, we have, what do you have to do? You have the patient's vagal, and if that doesn't work, we start giving medicine. And if someone's in SVT, have you guys ever given adenosine before? You ever do that in
Once.
training or anything like that? Yeah, so it works very, very quickly.
Yeah.
It has an extremely short half-life. You want to try to give it as close to the heart as possible. So if they have a central line, you're like golden. If they have a peripheral, you're supposed to push it real fast. You chase it with a flush, and even sometimes lift their arm up just to get it there. You're literally shutting down their AV node, okay? So if patients are awake and conscious, you have to warn them that they're gonna think you're killing them, because you're just like literally unplugging the heart for a second, letting the computer reboot, and then plugging it back in. It is shutting down the AV node, okay? So if someone was in atrial flutter, with that flutter, and every couple beats making it down, if you give adenosine, you're giving a treatment that works here. You're not doing anything to interrupt the flutter, but what you'll see is saw, and eventually the medicine wears out, and then the cars start going through again, but it allows you to make the diagnosis, all right? It's a little bit of a potent way to do it. That's why you can just get by pushing on the, but sometimes, I'll be honest, these people are so, their sympathetics are so revved up, and this doesn't do you have to just do something to break the, to slow things down just for a second to do it, okay? Now, sticking along the same things, and
Just to clarify, so vagal maneuver and then you reach for adenosine next in.
I would usually try vagal a couple times,
Okay.
and again, but you want to be looking at the monitor. You're not looking to fix it.
Yeah.
You're not looking to make it go away completely. As soon as I showed you guys this, you knew it was atrial flutter. You're just looking to see if you can see enough on a rhythm strip, even if it's for like, all you even sometimes need is to need them drop one beat, and you can see flutter, 4 of them, and it goes right back just to help make the diagnosis. So if they're in the ICU and they're intubated and you got some blood pressure to work with, they're not gonna necessarily know so much. But if you have an awake patient and I'm like in the ER trying to figure this out, I won't exactly come running in with adenosine, but if I can't figure it out, I sometimes have to do it. But if they can work with you, you can have them hold, you tell them to hold down like they're having a bowel movement, you're trying to blow up their thumb and, try to blow up a balloon that won't blow. You can have it, you're just looking to slow it down for 10 seconds and it does the trick, okay? So if we switch the page here to 18, what do you notice about this one, the one up top?
It's rapid.
Rapid and regular.
Rapid, narrow, and regular. So we know it's not coming from the ventricle. It's regular, so it can't be AFib. The hardest thing would be, is this SVT? Or is this like an atrial flutter like we just looked at on other EKG? Couple things. What do you notice about the rate of this one? I don't really see P waves in here.
Fast.
It's fast, so it's over 150 beats per minute, right? So we're talking like 200 beats per minute. So usually if it's atrial flutter, you'll see it around that 150 range. Very rarely does atrial flutter go this quickly. You'll see one case every 5 years where a young person goes into it and you have atrial flutter, what we call 1-to-1 reduction, but they usually feel terrible. But this is going very fast and it's regular. So, what is SVT? So SVT is the only other one we sort of haven't really talked about up here. SVT, again, we already talked that atrial fibrillation, if you had to put a pin in the heart, it's coming from everywhere. Atrial flutter, if you had to put a pin in the heart, it's the race car going around here. If I had to put a pin in the heart to show where SVT was coming from, it's a circuit that sets up shop right in and around the AV node itself, okay? People are born with, you have these fast wires, these slow wires, everything in your AV node, it's more than you guys need to know. But in certain people, you guys see it all the time, a PAC, a PVC, we get them all the time, we're having them while we're sitting here. It hits at the right time, and basically the heart gets stuck into a spin cycle, and it's going right in and around and through the AV node itself. So if I actually put a pin in the heart where the problem is, it would be actually right going through the AV node. That's where SVT is sort of going up and around. And because it's so quick and it has nowhere really to travel to make it down the Purkinje fibers, that's why the rate can be so fast. It's like super maximal capacity. It's like throwing cars onto the highway, even though it doesn't, the AV node doesn't want to work that quickly. We had
re-entry pathway, is that what that is?
well, so there's different things, right? So so these are all reentry pathways. There's AV nodal reentry where everything's in the node itself. And then some people have these things called bypass tracks where it does travel a little bit outside and pick something up in the atrium. For your guys' purposes for this, it's narrow and it's regular and it's fast. And the reason we give adenosine for SVT when a vagal maneuver won't work is, I already told you, adenosine shuts down the AV node. It's like putting the stop sign down. You're actually, for people that are in SVT, you're actually throwing a grenade right into the spot where the rhythm is truly originating, okay? SVT is going on right in the AV node. I put in adenosine, and it's actually truly interrupting where the circuit is. Does that make sense? If someone's in atrial fibrillation and I give adenosine, am I doing anything to interrupt the atrial fibrillation? No, it's just gonna be fib, 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 and then eventually it'll start making it down. Atrial flutter, am I doing anything to interrupt with this medicine where the rhythm is? No, you're just slowing how many beats make it down. The SVT actually at some point has to go through the AV node. So the reason we give the adenosine is you're literally throwing a rock right where the circuit needs to go through and you're hoping to break it apart, okay? That's why we run to give adenosine for SVT, because it's actually treating at the spot where the problem is, okay?
How does that affect your cardiac output? I mean, is it?
What do you mean?
If you're just like shutting it down, what does it do to the ventricles as?
Oh, you watch them go, so we'll talk about the brady, it's probably maybe a little too much unless you guys wanna keep going for today to do the
Yeah.
bradycardias.
Okay.
Basically, luckily adenosine's half-life is literally like 5 seconds, so
Okay.
it comes and goes very, very quickly. That's why sometimes you'll break the rhythm, and if you have like a young girl that was out dancing with her friends and had 3 Red Bulls and vodkas, it comes right back because it's so short acting, you have to give it more than once. Your heart has these escape rhythms, don't forget. So
Okay.
we've talked about all the fast stuff so far, but the heart can also go slow. I already talked about the AV node protecting us by letting only certain cars go through. Every cell in your heart is actually always trying to beat the heart, okay? The heart typically listens to the fastest conductor at a time. So you have the SA node that's firing out beats, and when things are going normally like we all should be here right now, every other part of the heart is trying to beat, but it's just being trumped by what's going faster. So we usually say your sinus node beats at about 60 to 100 beats per minute, whatever. Your AV node itself is actually always trying to beat the heart at about 40 to 60 beats per minute, but it's getting trumped by whatever else is going on. And even your ventricle is always trying to beat your heart at like 20 to 40 beats per minute, but it's being drowned out by everything else going on, so it never really happens. That's our backup generator. So God forbid, as we get older, our heart starts to slow down. Let's say the SA node just shits out on us at some point. You hear us talk about people going in a junctional rhythm or a ventricular rhythm. These are like the backup generators that kick in to keep us from dropping dead. Now they're not be-all end-alls, you end up with a pacemaker eventually and all that kind of stuff. So when you give adenosine, these people they go like this, you see like a flat line, and then you'll see like a junctional beat, or a ventricular beat, something from one of these escape rhythms kicks in until the normal conduction picks back up again. That's why when we use it, luckily it's extremely short acting. The most potent AV nodal blocker besides the adenosine that we sometimes are forced to use, if you guys remember a couple years ago, there was a shortage of diltiazem. So we had to use verapamil. Verapamil is extremely potent to affect the AV node. It's actually stronger than the diltiazem, and it has an extremely long half-life. So there were a couple patients that were like in rapid AFib, the metoprolol wasn't touching them. A couple of these patients just got like 5 of IV verapamil in the ER, and like a half an hour later, they just like completely shit out because it was so long acting. The diltiazem's nice, you turn it off, it's out in like 10 minutes. This stuff was on board you gave them 5 of IV, it was in their system for almost 2 hours, and then if it was too much, you would just sit there and wait for this stuff to come out. So the reason IV verapamil, even though it's the most potent, isn't a first-line agent is because it's very easy to overdo it with that drug. The adenosine, the worst you're gonna do is either it's not gonna work or it's gonna work temporarily. But either way, it's gone in 5 seconds. You can only do so much harm with the adenosine besides have the person cursing at you after they wake back up a little bit. You have to warn them you're giving it because it's potent with things, all right? So that's a very turbo course through like the fast stuff that you're gonna see. Questions? Is that helpful? Is that what you guys were looking
No,
for?
helpful.
I love the analogy of like the cars and the entry ramp, like you
Yeah,
just,
so it's
those
more for you
analogies
guys,
are really
the
helpful.
ACLS is a decent class, and if you, when we teach it, and when you actually, everyone gets overwhelmed with the rhythm, any monkey can read an algorithm, if you know what you're looking at, you just follow the boxes. That's not the hard part. The hard part is you gotta know what you're looking at to follow the boxes.
yeah.
But when you take a step back and realize that on all those tachycardia with a pulse, they don't name one rhythm in that entire thing, they just ask you to describe what you're looking at. Is it narrow, or is it wide, is it regular, or is it irregular? And even in the box on that algorithm, every code card here should have the cards, like the ACLS cards. Even for the unstable people that you think you have to shock right away, and it tells you the joules, it doesn't even say what, it says narrow, regular, 100 joules, narrow, irregular, 150 to 200 joules, wide, regular, 150 joules. It says it right there. They're not asking you to remember what it's called, just take a step back and describe what you're seeing. And the whole theory behind it is, all right, if it's narrow, it's coming from the top of the heart. If it's wide, a little more hop in my step, it's coming from the bottom of the heart. But even then, are they just a little sick, or are they truly unstable? So you know, just take your time. Never want to miss something. I'm not trying to undertreat people. But on the other hand, you don't have to go from point A to point D without sort of, just like you guys, I would be in the OR. I'd be nervous, and you don't want to skip your steps, you know what I mean? If you do the same thing for everybody, that's how you don't make mistakes when things get a little bit harried. It's when you start cutting corners and that's when mistakes start being made. And just ask. It takes 2 seconds for someone to look at an EKG that's not good. They don't have to physically cut, it's easy now. You can log on and do stuff. So that's that kind of stuff. Is that okay?
Yeah, it's
All
very
right.
helpful.
I think we go